the Viva-based discussions. Today, we are having the third episode by our orthopedic surgeons, Dr. Bandujeewa Piyasena. I think Dr. Ajit Tukkadarachi is having a difficult time attending to the meeting today. Nevertheless, today we are planning to discuss principles on pediatric hip problems and principles on management, basic principles of management in closed and open fractures. So, can I know who is the candidate for the pediatric hip problems?
Me, sir.
All right. What's your name, Puta?
Ravini.
Kavini.
Yes.
Kavini, now Dr. Banduji will follow you along the discussion.
Thanks, Dr. Pindo. I think this open fractures, that day we discussed, I think.
Yes.
Some part of management.
Yes, to some extent we discussed.
Yeah, yes. We discussed. No, yeah, I think that's mainly. So, you have put this good topic, which is a limping child. So, what's the name of the student that is who is participating with us?
Ravini.
Sorry, Ravini?
Ravini, yes.
Okay. Now, so what are the things that come to your mind if you see a child, say 7 years, as we have put here? If a child of 7 years comes to you with limp, say one-sided, say right-sided limp, which has been there, say, for about few days, not very long, recent. What, 3-4 days, let's say?
Okay. So it could be infection like septic arthritis, or transient synovitis. It could have a Perthes disease, or juvenile idiopathic arthritis, and
yeah, you are giving various reasons. How do you think about these things? Now, one thing, when somebody presents with a problem like this, now you have told, I told the child is limping, right?
yes.
So how do you set about now? Actually, if you have a practical approach, the child is with you. Child is in front of you, brought by mother, say being carried. Child was carried. You, I know, not walking even. Say, put it that way. 7 years.
First, I would ask whether it is painful or painless.
Very good. The degree of pain. Commonly, yeah, that is very good question. Yes. Then
I would see whether there is any reduction in the range of movement.
Where?
Of the hip joint and
so why, now let me ask this question. Joint. If you ask somebody whether you have pain, what is the very next question you must ask?
The pain is?
Yeah, now you said you asked whether it's painful. From this child, you are going to ask whether it's painful or not. No, that's the first question you asked. No, child was brought by the mother, was carried. You were not walking even. You asked whether it's painful. So what is the question now? Child is limping.
Yes.
Yeah. So.
So I'd ask where the pain is, or
exactly.
Whether it's...
That's the most important thing. Now, if somebody says pain, the important question is where the pain is. Did you get it?
Yes.
Okay, so you ask where the pain. Say if the child says, I have pain, I'm limping because if he pointed to his ankle, say right ankle, then what you're going to think, because anybody with pain in the ankle also will limp. Anybody with pain anywhere down this leg, starting from the hip and then the even spine, will limp, no? So yes, don't just narrow down just because you saw this. I think you have seen this X-ray. That limping child can have only hip problems. So this particular 7-year-old child was brought to you by the mother. He was being carried. Then you ask why? Why are you limping? They said it's painful. Then you ask first. The very next question that should follow is where are you pain? Because without knowing where the pain, you are not going to examine the child. Isn't it?
Yes, sir.
So the very next question, where your pain is. So then because if somebody says pain, the very next question that should follow, unless he mentioned it, where is your pain? Otherwise, you can't deal with this problem. Okay, then where your pain is? Then say
With
this
the
child says, so my mom says, you said you have pain, and child says, I have a pain in the knee, right knee. How do you set about then? 4 days.
then I'd ask whether there was any trauma to
Very
the
good.
site of the pain.
Yeah. So you think it's a traumatic. You want to exclude that problem. Okay. Trauma where?
To the site of the pain he mentioned.
Yes. What do you mean by that? It's a big sentence. No, you can tell in one word. No? The child is saying pain in the knee. So what you said, you asked if the child had pain in the knee, trauma to the knee. Am I right?
Yes, sir.
Yeah. So then you ask, very correctly ask the child, because he's complaining pain in the knee. No? So the first thing actually, whether he had pain in the, whether he had problem, trauma to knee.
Yes, sir.
Okay. So how will you proceed from there? So one likely cause is children walk about, they run around, and then they fall. So that's a possible event. What is?
Whether there are any pain with putting weight on the joint.
Sorry?
Whether there's any whether there's any swelling or erythema or signs of inflammation.
Oh, that's something that you do during examination, but doesn't matter. You can ask whether the knee was swollen. You can ask that also, but that's okay. Yes.
I'd say whether he has whether he has the pain is whether he had pain when putting weight on the leg.
Whether he's able to put weight on the leg. Okay. Now let's think like this. Now we are asking for a question and we are trying to identify that this child has problem in the knee. Now we are asking various questions in a very haphazard way. Now we won't get the diagnosis that easily if you follow this method. Now you can have a free mind and start thinking. Say I'm telling this 7-year-old child was brought by mother to you and was being carried, and he says this child, mother says child is limping for 4 days, and then you ask the question, whether the child has pain? They said yes. Then you ask where? Just in the knee. That much you have gone. And then you ask whether there's a trauma. Then I said, mother said there was no trauma also. So if we bring out this problem, if somebody says pain in the knee, what are the things that you should know? If especially a child, could be adult also. Pain in the knee. Sometimes maybe lower thigh also. What is the thing? So what you have to realize is pain in the knee doesn't necessarily mean the pathology or the problem in the knee. Why is that?
Because there can be referred pain as well.
Exactly. There's a thing called referred pain. Right? So pain in the knee may be due to problem in the knee or may be due to a referred pain. Pain referred from somewhere else. So what are places that you think? One of the commonest places is hip actually.
Hip, right?
Yeah, hip. You are quite right. Hip.
Thigh.
Yeah, hip. Mainly hip problems get referred to knee, and not necessarily maybe the lower thigh, that area. Sometimes real typical knee. Where else you get referred pain to knee? From where else? What is the common place? Spine. That's another very common problem, especially adults. But children also can get. If you get pain in the knee, it could be a referred pain from the upper lumbar. nerves. So they don't have, if you examine their knees, they are perfectly all right. They're working, no swelling, no tendon, nothing, absolutely no features of inflammation. There is a referred pain. So as soon as you, just because somebody says, I have pain in the knee, you ask when there's pain, where it is, then child says knee, but still as a medical student or as doctors, we have to know that answer has certain things to there think about, whether it's a pain of knee origin or whether it's a referred pain. So there are certain other places also like that. Say foot pain, commonly referred by the spine. So you think whether there's a foot pain or actually referred from the spine. So the pain, so somebody says pain, yeah, the first things to exclude whether we are talking about the pain in that particular local the area that was described by the patient, or whether it's a referred pain. That is number one to exclude. Otherwise, we will be. So we have to bear that also in our mind, right? So bear in, so this child, let's say knee pain, and then how will you proceed to examine? How will you think about this problem now? How do you sort out? Because now if we start asking here and there questions, we won't be able to get anywhere. Is there a logical order that you can think so that we won't miss out important things? One thing, you have to have the knowledge about the possible illnesses. That is true. But at the stage that you don't have all that knowledge now. How will you think about this problem?
First, I would examine structures related to the knee.
Yeah, quite right. If somebody says, you go by anatomical things. If somebody says, there's a problem in the knee, if you think it is the knee, think about the anatomical structures that are there. So it has to be one of them, having excluded referred pain. Because if you think in terms of referred pain, you have to know that there's no point in examining local, we have to go to the original site. But if you feel this referred pain, how do you understand whether referred pain or not? If it's a knee, say if somebody says pain in the knee, how do you know there's referred pain? Any idea?
If there are no, no, sir.
Sorry?
If there are no symptoms related to the knee area, then it
exactly, there are no other symptoms of especially the physical signs related to the knee at all. If you palpate, if you look, if you do palpation, if you see the range of movement, they are all normal. Which means you know it is unlikely or less likely, still not impossible, but less likely. So that's how you exclude. So if you think that it is from the knee, then how do you think about? You think about anatomical structures. Could it be from the skin? Could it be from the muscles? Or from the bone? Maybe the neural structures? Maybe the vessels? Think about all these things. But what else do you think? What other terms, in what other lines do you have to think? Do you think in terms of anatomical structures that could be involved? Second, other thing? Other thing is pathological processes. No? Yeah.
Yes.
You have to think about pathological processes. If you think in those two lines, you will not miss out anything. What are the pathological processes you are going to think? You don't know all the types of pathological things that happen in the knee or hip. No, that is not your level. No? So how at your level, how would you think?
I think about common features for infection, inflammatory changes, any vasculitis features.
Yeah. What else? No, you go to your one of the first few pathology lessons. Etiology, no? So you always start thinking in that line whether this is congenital or acquired. If it is acquired, now this is not the case of congenital anymore. Acquired, what are the acquired causes you know of? Whether it is infective, whether it's inflammatory, whether it's neoplastic, whether it's traumatic. What is? What is?
This
Metabolic?
Trauma.
Traumatic, we already mentioned. What is? Idiopathic? Sorry, not idiopathic. What is this called? Arterogenic? So you go through that lesson. So if we think about these two lines, you would know, okay, this is the anatomical structure that is involved. This is the pathological process. If you can say, okay, this is a joint involving, this first problem involves a joint and it has most likely infective etiology, then you are through. Or if you think this probably involves the knee joint, but it's a more degenerative process, then you know. Or if you think, oh, it involves hip joint, most likely traumatic, then you know what it is. So if we have those ideas, then we would know how to go. So that is why what I generally recommend to medical students, so that you will know what and you won't miss out anything. If you see a problem, you think of all these lines. So could it be infective? Could it be neoplastic? Could it be degenerative? Now in children, you don't think of degenerative, but in appropriate way, using your common sense, you apply this so that you will not miss anything. So as you go along, when you come across a lot of patients, once you see a lot of patients, then you will know what common things are common, and then you will go into that order. But even on those occasions, in order not to miss anything, you have to apply these principles. So similarly, so this now patient came with the knee. So we say you examine physical, there's nothing wrong in the knee, right? Then we clearly know it is not a knee pain, because remember I think you have seen this X-ray. You have seen this X-ray, no, aren't you?
Yes, sir.
You see, so this child will invariably, this of course advanced case, but this child will invariably come with a knee pain. Very unlikely to come with hip pain. So this child, so you examine. So this is the background that you have to start thinking. Otherwise, I mean, I'm not going to teach you what birth is. This is no. I want you to learn how to attend to a person coming with a child coming with a limping problem. How would you think about this problem broadly, right? So remember, if somebody is limping, that is from toes to back, not just hip, right? Otherwise, you think that everybody coming with this problem will have this thing. So we have to first find out where this problem is, and then you concentrate on that area, bearing in mind this area that they are showing may not be the exact area, because there is a thing called referred pain. And then what you do is, if you identify the particular area, then you think in terms of what anatomical structures are likely to be involved, or one or more, or if that is the case, what's the pathology going in this particular anatomical area. Then you would know broadly what you are, and you won't miss out. So have you ever seen a patient with Perthes disease?
No, sir.
No. So I think still coming back to the same topic. So what are the important questions that you will ask from this patient in order to identify the broad areas that he fall into pathologically? Say so let's forget about that. Let's think, how would you set about this child doesn't have a pain in the knee on your examination, no tenderness. How would you know whether it is coming from the hip? What are the how can you work it out? Hip problem.
Whether we can ask about the site of the pain, or whether the
Site of the pain very clear now. We told knee is pointing the knee, but now we examine the knee to realize nothing there. So now we assume that it's a hip. Yes, assuming. So how do we confirm now whether it's originated from the hip?
We can check whether the knee pain exacerbates with the movement of the hip.
Very good. You must remember, hip is a deep joint, unlike the knee. So you can't expect to see swelling or other signs of inflammation. You won't be able to see. So in the hip, you are not going to see. If you see swelling, that is well and good. That means very advanced, because it's a deep joint. So you can't expect to see swelling, and no, you won't see the other signs other than deep tenderness. So the most important thing is the movements. So what do you think will happen to the movements?
The range of movements will be reduced.
Yes. So movements, if you carefully analyze, especially compare with the other side, you will realize that the range of movement is reduced, right? And so especially the rotations, that of course will come with experience. Rotation, abduction, adduction sometimes very difficult to elicit because anyway they may not move, but rotation is the nicest thing to examine and understand. So movements are reduced. That's how you do. And what will happen during your movements? What will happen when you move the hip? What will happen? Just guess.
There will be a pain or there will be limitation.
Yeah, it will hurt him. It will hurt, and there will be pain. Then you know, okay, this guy has reduced range of movement and the pain becomes worse or pain appears. The child is nicely sitting, when you have movement, then you know it's from the hip. If that is also not there, say you have nicely moving hip and no pain when you move the hip, then you have to go to spine and see if the child has an issue with the spine. Okay, those are the known places, you know. Assuming that this child has pain during movement of the hip and also reduced range of movement of the hip, what else now would you like to do? Tell me how. Now think about the things I told. Now anatomically we have roughly got at the place. That is a hip joint. But of course you may not have excluded all the other structures. Now how else will you think? Would you think? Reduction of range of movement means very likely the joint, but nearby structures, if they are badly inflamed for some other reasons, also can cause some. So you have to think open in a very open way. So how will you apply now this problem? Now, so let's assume that it's a hip problem. You would like to get the child to walk and see whether how much weight bearing that child can do. That will tell us what kind of pain he is having. If child is walking with a limb comfortably, with reasonable comfort, then we know the problem is, kind of one set of. The child is not willing to keep even the foot on the ground, and there's another problem. And if the child doesn't allow you to move the hip at all, that means in severe pain, severe restriction. That will be another thing. What are the questions that you will ask at this stage? Because you have sorted out this problem. We have located the problem. Now, how will you set about to do the rest?
I will ask whether the child had any fever, symptoms of infection to exclude the infection.
I did hear whether the child had any
fever to exclude
fever.
Yes, to exclude septic arthritis and infection of the joint.
Exactly. So you are going to think in terms of infective origin, and so you'll ask whether child had any fever. What else would you like to ask straight away? Fever, loss of appetite, ill-looking child for the last few days, vomit, those things you would like to ask, no? So that's so clear in that line. So if they are not there, then you know it's less likely. So what else would you ask? Now, why don't you apply the things that I just mentioned to you? Now you're after the pathology.
Yes. The progression of the pain, whether it was
no, you asked whether the child had a fall. No fall, one thing. Is there a significant fall, or you think in terms of traumatic? What else would you ask?
Whether there's any recent viral infections or any other infections.
Very good. Any other infections? What do you think there?
It could be transient synovitis.
Transient synovitis. That's a post-viral syndromes. There's an infection, but it's a post-infection. So you answer that also. Yes. What else? Malignant neoplastic things unlikely unless you dig out, because sometimes our parents also try to prefer to shorten the duration and mention in order to avoid, because child may be having mild symptoms for a long period, but they say child just started limping 4 days ago. That is where the things became worse. In order to avoid any blames from the doctors, because then if you say 6 months, why didn't you bring? but they have been mild. So sometimes they modify this duration also. Bearing that in mind, in a practical situation, you can ask few questions about whether child had any problems before, prior to this 4-day period. Then they say on and off child used to get this, but we ignored. Because what could that be then? If it's a mild symptoms going on for 6 months?
It could be a neoplastic, or it could be an
On and off symptoms, more likely in favor of some sort of inflammatory process.
inflammatory condition.
Because remember, there's this called this inflammatory conditions, arthritis, very common. No, pediatric group. Do you know
Yes,
that?
sir.
Like rheumatoid arthritis, you have the pediatric group of. Do you know that?
Yes, sir.
Juvenile
Juvenile
arthritis. Various forms are there. So that could be that. So what else? That is our inflammatory cause. What are the things? Degenerative, less likely, no? Forget about. Any other, you have to ask the family in the history whether it suggests any metabolic disease, right? Any other this thing, because remember, hip pain can be a problem, sickle cell anemia, there are a lot of other results, and maybe just I'm just giving hemarthrosis. Suddenly, for 4 days, painful hip. I'll even diagnose hemarthrosis. What's the reason for hemarthrosis? Hemophilia.
Hemophilia.
These are practical things, right? And ultrasound will also mislead you, right? There. Forget about those things. So remember, unless you go into detail, you will miss somewhere. So always now, you don't say, assuming that you don't know anything, but still if you, so any weight loss, any these things, we suggest any things like even pyrexia, weight loss, those things, we suggest either chronic infection or even maybe manioplastic. So think on those lines, and metabolic, this traumatic, so that you won't miss out anything. So work for the anatomy, work for the pathology. Then you would know where broadly won't miss. Right? So that is the concept that I want you to learn. Otherwise, just learning, thinking that those child coming at this age with limpis, Perthes disease is not the right way of analyzing, because you will miss out a lot of things by that method. You will diagnose, you will think Perthes disease for a case of juvenile arthritis, or case of TB, or case of some other bone cyst or some other things. So you have to have that broad, and then you can apply it anywhere. They're simple. So I think that's the way to approach. Then, having mentioned that, then of course you can think about some common causes, common conditions in the hip, which could contribute to limping. Now that topics, if you come now, Perthes disease is one of the common among them, right? So this, what do you know about Perthes disease? Do you have any idea about Perthes disease?
It is due to avascular necrosis of the femoral epiphysis due to interrupted blood supply. It is common in males, and age of onset is within 2 to 12 years.
Sorry, not clear.
Age of onset is within 2 to 12 years. And
it's a little long. I mean, I thought it's little later, like around 4 to 5 years. It's finished by about 10 to 11 years. 2 years, not very common. 2 years, right? It's about 4 to 5 years, and then comes about 10 to 11 years. That's all. But okay.
It can be bilateral in
Okay.
as well.
Yeah.
It is a self-limiting condition.
Sorry?
It's a self-limiting condition.
Yeah.
But it can lead to complications like osteoarthritis later on.
Okay. So you have read very well about Perthes disease. That is very good. No? What other conditions do you like to think about here? You mentioned one very important condition, transient synovitis. One of the commonest conditions. So how will child, I'm not going to discuss now each and everything in detail, right? That of course we don't have time for that now, right? Transient synovitis, how do they present?
They present with pain and limping.
Yes.
Usually it is proceeding upper respiratory tract infection.
You may or may
pain
not find, but usually sometimes. But there's history, that's very critical. And what else they find there?
it's difficult to bear weight on the joint.
Okay.
Due to pain.
Natural history?
It lasts about 1 to 2 weeks and it subsides
Yeah, it
spontaneously.
disappears. Child is typically not ill looking. And maybe limb, child may be even running with the limb. Pain is very much less. Unless child dances, pain is very much less. But there's a genuine, you can see genuine limb. When you examine the hip, you can find some limitation of movement sometimes. Not very common that also, but sometimes. And then do ultrasound scan, you can sometimes find fluid, not always. It's a clinical diagnosis. And then you have to, of course, you have to very carefully follow them up because it may be the beginning of anything else that you are going to miss unless you label this is transient synovitis on day 1. So it's a kind of a you follow up and retrospectively when it subsides, you diagnose that as okay, right? Because if you think that it is day 1, you are going to miss quite a number of other conditions which will come. For example, the beginning of inflammatory arthropathy. So it's a kind of a thing that you have to be very carefully, you have to label it. What are the things? Somebody, another thing, very important thing, no, I bring out. One thing is birth is we must know this. Other things, what? You know, this goes SIP, upper femoral epiphysis or SIP, capital femoral epiphysis. Yeah, what is that? Give me the picture of that person. Yes. Because this clinical picture you should remember. Then you won't miss out. So what's the clinical picture? What kind of person are you expecting to come with this problem?
It's
what kind of person?
During the puberty.
Yes. So what's the age group? Roughly about 5 years remaining in puberty. So it's about 10 years, right? 12, right? Maybe 8, 10, 10, 11, 12, that kind of period, right? Maybe a little later also. So that's the figure. So what kind of figure will that patient have?
It could be overweight and tall.
Generally obese. General, not always, remember, but generally obese. So obese child of that age coming to you with a limp of recent onset may have had few episodes before. So always think, okay, could it be slip? That's how. So how do you examine them?
There will be limitations on the movement, hip movement, reduced internal rotation.
Typically, there will be limitation of hip movement, will be limping, weight bearing will be painful, and there will be limitation of. So by that, but you must remember there's acute and sometimes chronic and acute on chronic. But all you find is this may be the first episode. He may have had few episodes which are sort of settled on its own, right? So remember that kind of history may be there. And this is if you have to do X-ray after covering his genitalia, you have to do X-ray. There are special types of X-rays. One thing is actually it's not visual. One thing is the anteroposterior view. Second one is a frog lateral. Exactly. And then there are, you have to know the radiologically what the signs. I mean, those things, I do that if you know, but I am not expecting you to know all that. But so you can diagnose. This is something that you should not miss as a or doctor. You must pick them up. If you are not orthopedic person, you must know this much and suspect and refer to the appropriate person. That is all. What else do you want to think?
I'd also look at septic arthritis.
Sorry.
Septic arthritis, sir?
Very good. Very good. So in that case, child will be in severe. Clinical picture will be in severe pain, fever, ill looking, that kind of. What other ways can they present, do you think? Remember, this child, especially child is very small, neonate, the presentation may be completely different, right? They will be very sleepy. You may not be able to even, they can't express themselves, right? And so the presentation may be very difficult. And remember, other aspect is a partially treated septic arthritis, because sometimes children, when they get hip pain, they are taken to GP. They start antibiotics. Some people, even without major signs, or fever, antibiotics. And what happens? Then he goes to some other person, take it over. So you see partially treated septic arthritis without so-called signs and symptoms that we mentioned before, right? Or, sort of milder version of them. That is where the confusion starts. Child has a history of low-grade fever, then the child has improved, then the limping is also. So remember that in this, so you quite rightly mentioned this here because it's very important to know. There can be partial treated septic arthritis which has been going on for a week or two. Because if they started treating very early with antibiotics, even with oral, it might have worked half, but not sufficiently. So the disease went on because it was duration was not enough, probably dose was not enough. So the root was not good. So remember that category. So infections. The other rare category is a TB, not common in children, but TB is the other chronic infectious thing. So what are the hip problems you don't think? I think when it comes to children, sorry?
Juvenile idiopathic arthritis?
Yeah, that is the other thing that we have already just mentioned. That's another thing that you have to think. Again, the presentation. And then other thing is the neoplastic paralysis, right? So in the pain in the hip, you have to examine the hip and also the back, right? The scapula, the body says the ilium, then the sacroiliac joint, right? And the spine, all these areas should be examined because the problem may be there. So unless, now we assume that the problem is in hip for this your presentation, but remember that you have to examine all that area. That is if we confirm, because nobody will come with the saying that I have a problem here. It's up to us to diagnose. They will mention various places. You can't say at the end of they mentioned this place. That's why I didn't examine that area. So limping child is a very broad term. First, you have to figure out where the problem is, and then whatever. First, number one, whether it's a referred or not. Once they mention the place, then the anatomical structures there is involved. Now here, remember, I concentrate mostly orthopedic. But do you think that they limp only because of bone and joint problems? What are the other problems that will make somebody limp?
Due to a muscle and tendon problem.
Exactly, muscle weakness. And the neurological problems. So neuromuscular things are pretty common also. So that's why I said you have to think about the anatomical structure and you have to think about the pathology. Then only you will have a complete. Otherwise, you will just diagnose something that is in your mind and you will try to put that as a diagnosis, which may not be the actual case, right? So I think that is sufficient. I think there is some. Can we see that algorithm also? Is it for them also? But I don't think that's a very. Dr. Pinto?
Yes, sir.
You had there was an algorithm also, no?
Yes. Hold on.
Yeah, you can just show them, but I'm not going to discuss that. And these are the courses actually. I mean, we may not have mentioned. Come back to the previous one. Yeah, so there are a lot of what you showed before. The table. So not the algorithm table. Yeah. So remember, there are a lot of things, right? We just did not discuss all these cases, but remember. And remember about these overuse syndromes. I could mention there are common. Remember, children are during the sports period, right? And the children who nowadays we have even children coming to us who do sports regularly for their schools, right? So they present with various problems, various overuse syndromes, what you call overuse syndromes. Now that for you, because you do come across this group. So remember, so you have to go through that what overuse syndromes and find out what it is, right? Very common. Even you don't have to do heavy sports. Some children are more vulnerable than the others. So there are a lot of Osgood-Shatter, then that is very common. And then severs, and then jumpers knee, lot of places sometimes. So that's forget always. And then you see this called eversion injuries also. Completely it comes off the muscle with the due to muscle pull. Sometimes the apophysis comes out of the place. Anyway, so I think we have touched adequately that area, no?
Yes, sir.
Can we move to the next topic? Then Dr. Upatharach is there.
I think he had difficulty in joining.
Ah.
As we have touched upon the principles of fracture management,
Yes.
maybe if you don't have anything more to add to that from the previous discussion of ours, where we discussed closed fractures and open fractures as well during the upper limb and lower limb fracture management.
Yeah.
What do you think?
No, I think basically we have, I mean, there are things to discuss if you want, but actually,
Yes.
so we have now limb pain child, so they have an idea, so they can work out the rest from there.
Yes.
So
yes.
thinking broadly, and so they have homework to do,
Yes.
and then this you can go through, right?
Yes.
This you can go through. This, I mean, you can have various algorithms for a thing. This is very complex, but these are very, I think this is a very sort of like a, complete thing. But you can have minor version of this for your own listing, right?
Okay, sir. Then.
So okay, then what is the next thing?
Yeah. Anybody there for closed fractures?
Yeah, I mean basically, yeah. Who is going to
Yes,
come?
Sam.
Yeah. Will you introduce
Sir,
yourself?
I'm Harshana.
Very good. Harshana, now let's ask these basic things again, right? What are the principles of management of fracture? We are talking about closed fractures, right? Talking about open fractures.
Sir, first is V reduction. It's due to the restoration of the anatomy.
Yes.
Next one is stabilization and rehabilitation. The rehabilitation, again, we can categorize into physical rehabilitation and psychological and social
Okay.
rehabilitation.
Very good. Broadly, I would quite agree with you. Very good. So first, coming to your first is thing. First is the reduction.
Yes, sir.
What do you mean by reduction? What does that term mean to us?
Reduction means
as orthopedic?
the reduction means restore the anatomy of the normal person, sir.
Right. Fracture, you bring the fracture fragments to a normal or near normal position. So the next question is, reduction always necessary for fracture?
No, sir.
Why not?
There are few types of fractures. There are not into slip, or there are some fractures are not like wedge fractures we can't approximate. Otherwise, green stick fractures we can't.
What fractures you can't?
Wedge fracture in the vertebral column.
Certain wedge fractures, you are right, do not need because their wedging is very mild. But if it is significantly wedged, there are ways to bring back the height, right? So you need, okay. So there's a stable and unstable fracture of the spine. Where they're very stable, then so that's a bit of complex thing. But the most simple things.
So there's a fracture is not displaced.
One thing is the undisplaced fracture. Whatever the fracture, if it is undisplaced, you would have to do a reduction because nothing reduced because it's already undisplaced. Second category, there are certain fractures where you don't have to have perfect reduction to have a good functional outcome. What are those? Actually, so we are not reducing these fractures for the fun of doing it. No, we reduce if it serves a purpose. So certain fractures, even if you don't reduce 100% or perfectly, functionally we are okay, or we are reasonably okay. So what else? Can you give me some examples?
Carpal bone.
Carpal bones or metacarpal bones?
Metacarpal bones.
Carpal bones are different, no? Carpal bones need perfect reduction. Because it's a group of a bag of 8 bones which are anatomically nicely arranged. They are moving on each other. So if there's any issue with one of them, you won't be able to move the wrist without pain. You will move, but you will have a lot of pain. So those 8 bones have to be anatomically nicely reduced. So I presume you refer to metacarpal bones, which are long bones in the hand. Am I right?
Yes,
yeah,
sir.
They don't need perfect reduction, especially if they are located in the middle. Yes, there may be certain fracture, but not all. What other fracture? Anything else? clavicle fractures.
Clavicle
Clavicle fractures do not need 100% reduction in every person. In sports persons, there are certain indications, but on average person, they don't need, because functional outcome is very good, right? Not all, but it's a badly spacious. Even if you take a humerus fracture, humerus shaft fracture, even if it is displaced 100%, if the two bone ends are lying side by side, provided the alignment is okay, if they heal, that is fine, because shortening of the humerus is not going to matter much, unlike the leg bones. Because if you have a problem, a similar thing in the leg, then of course there will be shortening and you will start limping, but not in the humerus. So there are quite number and rib fractures, we never tried to reduce. I mean, hardly anything, unless there's a specific India. So there are cases like that. So there are situations where you don't have to do reduction. So if you do reduction, now tell me how you will do the reduction. What are the methods of reduction?
So we can close or open reduction.
Very
The
broadly.
close, yes, sir. Close reduction we can do a manipulation under anesthesia, and skin traction and other traction method we can
Other
use.
traction method also we used to use, yes.
Yes, sir. In
Those are close methods.
Yes, sir.
Yeah.
In open method we can use like a screw and other like metal, like screw and other internal fixation methods.
Yeah, if I ask you some details, you don't have to know all the details about these things. You won't fail the exam just because you don't know. But as a doctors in the modern era, I suppose you also, even as an owner doctor, even if you don't do orthopedic, you have to know what methods are available. One might want to be, somebody might ask. So broadly, have you done your orthopedics appointment?
Yes, sir.
You have, I presume, finally,
Yes, sir.
Yes, you have. So then what are the broad things? I mean, broadly, what are things that you saw as a fixation, as a, forget about that. So open reduction, now we are still in the reduction. So open reduction means you open and reduce it. Okay.
Yes, sir.
So we stop there, right? So that's what we are trying to discuss will come under stabilization method. No? So
yes,
open reduction means you open the site, fracture site and reduce. That's what you call open reduction. So now, so close and open. So what are the, now let's move to the next step. What is the other step of fracture management principles? Reduction you mentioned.
Yeah, stabilization, sir.
Stabilization. So what are the stabilization techniques now?
So we again we can classify into the open and close method.
Okay.
In open method we can do surgery, and close method we can use again plaster of Paris, traction.
Actually,
and
if you think what we generally do the other way. Now you mentioned the open and close reduction methods. The stabilization techniques, we put it like external and internal. Right?
Yes, sir.
Okay. So what are the external methods of stabilization?
So plaster of Paris.
Plaster of Paris cast is the commonest stabilization method which you use externally. Okay?
Yes, sir.
What are the methods?
Traction, sir. Traction method.
Yes. Another, because that's a way of reducing as well as maintaining reduction. Traction reduces the fracture, and when you keep it throughout, it maintains the position. Stabilization technique. It may not be very effective method. It may not be a very effective method, but that's another technique. Yes. Cast, POP cast, other things, because Scotch cast, which is very light, very hard. It's available, right? So it's a very and traction methods. What are the other things?
So braces, like we can movement in the joint, but other part of the joint is stabilized.
I didn't get stabilization. No, what are the methods of stabilization? You said cast. You said traction methods. What are the things?
External fixations.
External fixators. You are right. Of course, they will be having pins going into the bone, but the main framework is externally. So those are called external fixators. Now you have to, in your exam, you will be asked question about the external fixators, where they are used, and sometimes they will ask about types of external fixators. But you don't have to worry about, but where they are used and how you look after a patient with extra fixator, you have to know. It's like knowing the colostomy thing, right?
Yes.
So how you got it. So commonly nowadays extra fixator are applied. So as a doctor, you should be able to advise if somebody comes to you with extra fixator without being able to go back to the hospital, you must say, okay, these are we look after. So extra fixator. So there's another advanced method of extra fixation, extra fixator. There are various types,
Yes,
right?
sir.
Ring extra fixators, monoplanar, uniplanar, then multiplanar. There are various types. Those you don't know, but average you have to know. Because always there is a pin going into the bone. That may be a pin or that may be a screw. So that's called pin site, or the where the skin the screw or the pin penetrates the skin called pin site.
Pin
That
site.
is the area where that like to get infected. So we have to look after the pin site, like a colostomy thing, pin site, and the rest of the wound management there. So what are the other methods of fix? And now you said external methods. What are the internal methods?
So we can use screws and plates and wires, K wires.
Now, if you remember, you have to have better some idea. Screws can be used alone in certain places to fix the fractures. Not very common, but you can see the medial malleolus, you use only the screws. But mostly to fix the long bones, you use the plate and the screws.
Plate.
So remember to put a plate and put some screws, like a small, simple thing to remember. So what is the other technique that you use?
K wires.
Plate and screws, and what is the other technique?
K wires.
No, I think your knowledge is not very good in there. Intramedullary nails.
Intermediate.
So that's the plate is something that you keep on the bone with screws. Intramedullary is something you put inside the bone.
Yes, sir.
So there are things to compare. No, I don't think you will be asked those things, but you must know at least there are things called intramedullary nails.
Yes, sir.
Nowadays it's called locking. There's a thing called locking, which is done proximally and distally, so that around the nail, around the intermedullary nail, bone will not rotate. It's called distal and proximal locking. So now, not that just you put a rod inside, around which bones can nicely rotate. To prevent that, you put screws, distal and proximal. So it's called locking. So I'm called interlocking. So these intermedullary nails are, so they are locked proximal and distal. So now what is modern method? So intermedullary nail, other techniques, plate and screws. Those are two broad methods. But you quite rightly mentioned there are screws used, and you sometimes use K wires. Sometimes it's called tension band wiring technique. If you are good at it, you will know those things. They are used only special technique. So at least if you know, you use intramedullary nails and plates and screws. Those are two broad areas. In addition, screws alone and sometimes K wires to temporarily stabilize. That's good enough. But then the thing that you need to know, the advantage and disadvantages of these two methods. That is, as a method of stabilization, advantage of cast and that advantage and disadvantage of cast versus what do you call internal implants,
Yes, sir.
plates and screws. That of course you have to know, right? I'm not going to discuss. That is something you should read. That's one of the commonest things that we ask. Why do we put internal fixators instead of having things like cast? Then what's the indication of external fixator? Those are direct exam questions. You can find out. Then that is the stabilization method that we use. We're going through fast, right? We are running out of time. What's the last thing? But the most important thing?
Rehabilitation, sir.
Rehabilitation. Tell me about rehabilitation. What do you mean by rehabilitation? Because that's the most important area.
The rehabilitation is patient.
For ordinary doctor, this is the most important thing. What is rehabilitation?
The rehabilitation, we are targeting the physical and psychological and social rehabilitation.
Very good.
The physical rehabilitation, we can do increase the range of the movement and increase the muscle
of the joints.
Joints,
okay.
And increase the muscle power. And if it is weight bearing joint, we can again start in the rehabilitation program.
Weight bearing is, of course, depending on the instruction of the orthopedic surgeon. But mainly we are quite right to mention, because if a particular limb is involved, we have to maintain the range of movements of the joints in that limb right from day one. That is where the internal fixation becomes important, right? As opposed to a cast. So you can move the joints, all the joints. If you done interfixation, if it's a stable one, then you can start all the joints, because there's a fracture, there is surgery, there is there will be already the things may be very painful. There may be additional areas of confused areas during this injury. So you have to start working. And as you quite right, second, maintaining the muscle strength. You are not going to increase. You are going to maintain. Try and get what he has lost, and then maintain that muscle strength throughout, because you may not be using this for various the work that you have been regularly otherwise used. So the muscles will become wasted. To prevent wasting, you have to do the exercises. So and then there will be other certain disabilities, like there may be nerve injuries. So we have to do certain special rehabilitation methods to overcome them, right? So, but broadly, you're quite right, to maintain the range of movement and the muscle power are the two main things. But then in addition, there are specific injuries that you have had. You quite rightly mentioned about low limb injuries, how to mobilize the patient as a whole. So how you get them to walk, whether you're going to put weight or half weight or no weight. If it is no non-weight bearing, how are they on a crutches or this thing? So rehabilitation is the key thing. Those are the physical aspects. Psychological aspects are very important, because with an injury like this, they'll be psychologically completely, maybe completely devastated. So we have to address those areas. Social rehabilitation is very important, because we see a lot of patients, even if you operate, there are no places for them to go back. And the relatives are unable to take them more to them, because once they are disabled, remember in our society, once the people are disabled, there's nobody to look after. That's not the fault. That's not actually not the fault of the relatives or their parents or children. They are not physical. They are not financially in a position to look after a disabled person. So there's no social support system in our society. So social rehabilitation is a real challenge in our society. So I remember, so you are good in that area, but you are the rest of the other two areas you have to improve. So rehabilitation, there are a lot of areas we have a good rehabilitation, committed physiotherapist. The physiotherapist is somebody who should be really committed to research, to see proper results. If there's no rehabilitation, however good you may have done your surgery exceptionally well, but without rehabilitation, you will have a limb with perfectly anatomical radius, but without any functional value. So it's the duty of the doctors to see that rehabilitation happens, orthopedic doctors or others also. So rehabilitation part, which can be easily taught, but they have to be adequately taught, because people don't understand the value of it. They come back when the problems have already occurred, like stiff joints, wasted muscles. So from that point onward, bring them back to normal is a nightmare.
Yes, sir.
So in a nutshell, I think those are the things that we ask. You can read around those subjects.
Okay, sir.
Dr. Pinto, anything else?
Shall we speak a few things on the open fracture as well, sir? As we have
open fractures, I think that day I discussed.
Yeah, definitely.
Basically,
we discussed a lot. So I think
we discussed, and I told you how will you manage a patient presented to your visit emergency department as a house officer or a doctor. How will you set about? I may have not discussed the details how you exactly manage a compound fracture from an orthopedic point of view. That of course I didn't discuss, but something that you would know. But
anyway, I think that's about it, sir, today then.
Yeah, this is so you can get but read about the classification, right? I think worth knowing Castillo classification, Castillo-Anderson classification, and then any other questions you can raise later. You better read about open fractures. So we are going to ask. So basically, it's a wound management. How will you do a good wound toilet? But that day I taught how you examine the wound. What things you should examine in the wound, I did mention. All the anatomical structures you have to identify that area, whether they are damaged. Not only the bone, tendon, muscle, nerves, And there are difficulties in eliciting physical signs. That also you have to bear in mind. So you may have to re-examine and taking a photo, taking a culture, and then how you do it. So those things you have to do. And there is somebody reminded us of the toxoid that should be given, which we missed out initially. So antibiotics, how you find. So those things you have to know. I think we have discussed that basically.
Okay, sir. Sumu sir, are you there? I think he's not there. Anyway, yes. No. Right. Sir.
Yeah. So are you going to wind up?
Yeah, Sumu sir.
Yeah. Thank you, Bandujeewa, for very comprehensive talk on fracture management and pediatric hip pain and hip problems. Thank you very much. And thank you, students also.
Okay, good night.
Good night.